Okay,
We're all ready.
we'll go ahead and get started then. So good afternoon to everybody, and Happy New Year. This is our first webinar of the new year. So thank you to everybody that's joining the webinar today, utilizing palliative care and navigating the Our Care Act. So organizers of this training today, myself, I'm Stephanie Moyer. I'm the Community Initiatives and Training Coordinator for the Hawaii Public Health Institute. My colleague Makamai Namahoe, Grants Contracts Operations Assistant, also with the Hawaii Public Health Institute, as well as the Hawaii Public Health Training Hui Steering Committee, which is a committee of 14 members from a variety of organizations. Sponsors and partners for today's webinar, I'd like to acknowledge the Hawaii Public Health Training Hui, the Western Region Public Health Training Center, as well as the Public Health Learning Network. Continuing education credits provided for today. We have been approved for all areas for the 5 listed here. Along, you'll find your codes here as well, and I will be sending the PDF of the slides over to you, so you will get those codes if you missed them on this slide. Nope, you're good. Thanks, Maka. Requests for continuing education credits. So to receive your continuing ed, you do need to complete an evaluation of the training for today. I will be sending out the link to that evaluation following the webinar today. We'd like you to do that as soon as possible, but the deadline to complete that is Monday, February, oh, that's today. No, that's not today, excuse me, Monday, today's Friday. Oh, so the deadline is Monday, February 24th. For those that are calling in on the phone, please don't forget to email me. It's Stephanie, STEPHANIE, at hiphi.org, and let me know your phone number so I know to count you as an attendee for the webinar. If you have not received your certificate after 2 weeks, please contact either myself or Maka. For continuing nursing education information disclosure, the planners and presenters have no relevant financial relationships to disclose. Learning outcomes for today's webinar, we will identify people who would benefit from palliative care, distinguish between palliative care and hospice and make appropriate referrals, as well as implement the process for the Our Care, Our Choice Act for medical aid in dying. I'm very happy to introduce our speakers for today. First, we have Jeannette Koijane. She is the Executive Director of Kokua Mau. Kokua Mau strives to make advanced care planning and open communication about care and support for those with serious illness and their loved ones, including end-of-life care, the cultural norm. Jeannette received her graduate degree in public health from the University of Hawaii and her undergraduate degree from Cornell University. She has been involved with hospice and palliative care since 1988, beginning in the field of HIV/AIDS, working with the AIDS Memorial Quilt as the Director of International Programs, and then in a variety of research and educational positions in Berlin and San Francisco. Jeannette has worked in the US-affiliated Pacific Islands, helping to develop palliative care programs through a collaboration with the University of Hawaii Cancer Center and John A. Burns School of Medicine. She serves as a volunteer advisor to Zahana, a participatory rural development project in Madagascar. Our second presenter for today is Hope Young. Hope is the Advanced Care Coordinator for Kokua Mau, providing community awareness and coordinates the Let's Talk Story program of the former Speakers Bureau. Hope joined Kokua Mau in 2017 under a generous grant from the Subski Foundation. She has worked in various capacities with seniors and the caregiving community for over 15 years. She is a graduate of the University of Hawaii, West Oahu, and has a BA in Public Administration with a concentration in Healthcare Administration. Hope enjoys being out in the community and sharing the importance of advanced care planning, and hopes to someday normalize the conversation to ensure that everyone's end-of-life wishes are expressed and honored. It is my honor to introduce you and turn it over to Jeannette and Hope.
Thanks, Stephanie. Thank you, Stephanie. So we're good like this? Good. Okay, so thank you so much for the invitation to come today. It's really a pleasure. You notice that I am a public health person, and I think there is a tremendous opportunity with those of us in public health to really be improving the care that people in our community get when they have serious illness. So I really encourage folks in public health to be learning about this, learning about our work. Come and join our fabulous organization. There's just amazing people who are very compassionate. And as somebody a couple weeks ago, they said, you know, what I love about Kokua is that this is the spirit of aloha. We are building a community where people are cared for. That is what we're doing. And we're doing it by caring for our families, for our loved ones, for each other. This is what aloha is about. It's not easy in this case, but we really need everybody to be involved. And so I am so glad that you folks today are learning about some of the work that we're doing. And again, I encourage you, put yourself on our free newsletter, come to meetings, see how you can be involved. I'm really glad Hope gave a talk last year that some of you may have heard, and we're going to be building off of that today. So just to give you some basics, we are a 501c3, which means we're a community benefit nonprofit organization, not a part of a state agency, which people always think in Hawaii. Our members are all sorts of different organizations and individuals, so hospitals, health plans, hospices, churches, Office on Aging, Maui County Office on Aging. Around the state, there are people who are supporting the work that we do. And again, we welcome also you, and we definitely want some, we have amazing volunteers. So this is your invitation to get involved. So as I said, I'm a public health person, and I approach this problem in a public health way, which means a multi-dimensional approach. So we actually have 3 ways where we are trying to change things. How are we going to build a community where people are well cared for? How are we going to help prevent crisis, or if people are in a crisis, that they know where to go? And so our approach has like three legs on the stool. So the first one is that we want to work with people who may be facing serious illness and their loved ones to understand decisions that they may need to make as early as possible. So remember, prevention is key, or if they're in a crisis, to help them out. And that it's important also to say that we are always looking at the person and their loved ones. And I will say in my work over the last 30 plus years, sometimes the family is the problem. So I don't like to use the word family, I'm serious, because sometimes the family is the problem. And good thing for us, we get to create love, we get other loved ones. So if we're really gonna work on this, it's not just the person who's facing these serious illness, but their team. So, and what we wanna do is put the person and their loved ones at the center of this. And then how do we get them good information? How do we get them good resources? So we do things like we have an actively managed website. Visit our website. We have all kinds of free materials. Basically, everybody across the state uses our materials on advanced directives and pulse, understanding tube feeding and CPR, and where are resources available. So if that was on your to-do list, good news, you got more time, because just go use our materials. They're all free for download. We also have a speakers bureau. So Hope runs this Let's Talk Story program, and we like to go out, we like to say where people work, live, and pray, and especially we like to go out to faith communities and also to reach professionals. We like to think about the multiplier effect. So if you're thinking, hey, my mom's church is always looking for speakers, give us a call. So the first thing we do is work with people, and the second approach is help professionals. How do we help professionals do their job better? This is not an easy topic, but we think it's very important and also very rewarding. So if you sign up for the newsletter, you'll see that, for instance, every other month we have something called Palliative Poo-Poos, which it's here at Queens. It's a case discussion on palliative care. And you hear exactly, and if you wonder, well, what is palliative care? How does that work? How would people in palliative care be cared for? That's a great example. We have monthly meetings and we announce all kinds of other things going on. And then the final thing we look at is how are we going to change the system? What sort of policy changes can we make that raise all boats? Is there legislation? Fortunately, this year, no legislation. Last year, we passed legislation, which was great. We really try and see how can, we got to make sure that the right decision is as easy as possible. So that is our approach. We like to call ourselves a movement to improve care. And that really, the thing about a movement is that everybody has a role to play. It also implies that we're moving forward. And our goal really is to make advanced care planning and open communication about care and support for those with serious illness and their loved ones, including end-of-life care, the cultural norm. So we're only going to do that by having everybody participate in this. So welcome to Kokua. We're really glad that you're learning about this. So we're really all about getting the best care possible. And we want you to understand what types of care and support are available for people with serious illness. And then how can we ensure quality of life throughout somebody's life, especially once they're sick? And that's really the challenge, and those of us, for me, anytime you get the flu, you're like, oh my gosh, when this gets better, I will just be so grateful for not being sick. And people I work with serious illness, I try to be sympathetic and empathetic. It's very tough, and you're really trying to figure out how do you get the right care at the right time in the right place. So I want to describe palliative care, and this is a longer description, but we're going to go through it piece by piece. You just want to see me, okay? So the thing about palliative care is that a lot of people misunderstand it. So I want you to take a step back and pretend that you've never heard about palliative care before. It's a totally new thing. And now I'm going to tell you for the first time what it is. And I will tell you, I talk to people all the time who say, wow, I misunderstood palliative care. Thank you for explaining it. So this is the official definition that we like to use here in Hawaii and in Kokua. Palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of a serious illness. The goal is to improve quality of life for both the patient and the family. It's okay, family. Palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the patient's prognosis. This care is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatments. So we're going to go into some of these pieces, but I really encourage you to go to the Center for the Advancement of Palliative Care, of course not now, but when we're done, to see some of the great resources that they have and to learn more about it. So let's go through this. Palliative care is specialized medical care for people living with serious illness. So this is a medical subspecialty. Doctor, nurse, social work, chaplain are the usual people who are on a team. So this means when somebody has serious illness, that it is a group of people who are well trained who will come in to help. And they will come in and help with the symptoms and stress of the illness. That is what they are looking to do. And really the goal is to improve the quality of life for the person, but also for their loved one. So quality of life is the key thing that's going on here. So as I mentioned, this team works together with the other professionals who are helping the patient, and it also works together with the person and their team. So these are teams that work together. So I like to think of it as an extra layer of support. You're really not giving up anything by getting palliative care. I mentioned too that it is based on the needs of the patient. So we put the patient at the middle. What are their needs, and how do we help with that? It's important to say that palliative care can be offered at any age and at any stage in a serious illness, and it can be provided along with curative treatments. So it's really important to think about that you can, and I often think about this with people with cancer. It may be easier to think about. You get a cancer diagnosis, oh my goodness, that is very, very stressful. Who is going to help you with the stress of just coping with this disease? And then you start thinking, okay, who's going to take care of my kids? Who's going to take care of my family? Wow, has God abandoned me? Why is this happening? And this is before you start with radiation or chemo or surgery. So if you can think of palliative care and the addressing of the suffering and stress as starting early, and then, for instance, if people decide, well, I'm going to get some chemotherapy, and then you may have side effects from that, pain, nausea, all kinds of other things, the palliative care team also are the specialists in helping to make that happen, or in helping to manage those issues. So we like to think of palliative care as starting early, starting as early as possible to help people live well with the illness. I've mentioned before, the relief of symptoms and stress is really crucial. Quality of life, an extra layer of support, and then again, these are specially trained doctors, nurses, and other specialists who are working together. Anytime, any stage, and at the same time as curative treatments. So where is palliative care available? So if somebody is inpatient in the hospital, they can, I've listed here that Queens, Kaiser, Straub, Kapiolani, Wilcox, and Polymomi, as well as Castle, have inpatient palliative care programs. And the key thing is if a loved one's in the hospital or you're working with someone, ask for a palliative care consult. That is the key phrase that you should remember. So for a doctor would ask for a consult, or in some cases, you can go say, my dad needs a palliative care consult. Outpatient, there is an oncology supportive oncology clinic at Queens, which has palliative medicine professionals that are helping there. And then in-home, here in Hawaii, we have 3 options, except if you're in Hilo, and then you have another option. So people with UHA insurance and HMSA insurance can get in-home support. At UHA, it's called concurrent care, and they have no time limit. HMSA has supportive care, which is a 3-month benefit in a 12-month period. These are really excellent programs. They're provided in the home. It's a palliative care team that will come in and help. And I'm very happy to say that the VA has just begun an in-home palliative care program. We're not publicizing it widely, but sorry, I'm letting people know, because we're really pleased that this is out there. And then if you're in Hilo, there is a program called Kupu Care that is run through Hawaii Care Choices. So give them a call and you can ask about that. So first question, is there enough palliative care? Absolutely not. No, we need your help. And I would love it if all of you would go call your healthcare provider and say, hey, what kind of palliative care do you have? Let me know what they say, because we really are trying to get this to be, again, to more providers to saying, we understand the value of palliative care. We want more of it out there, because really palliative care is the way care should be. And Hope found me this fabulous chart, which helps to show some of the value of palliative care. It cuts down on readmissions, it cuts down on costs. We really see that it decreases emergency room visits. With skilled nursing, it really reduces these transfers in between settings that are not effective, and it decreases overall costs. So we're really promoting palliative care. This is one of the very well-respected people in our field, Dr. Ira Byock. I encourage you guys to go to his website, learn all about it. He says, modern medicine has yet to make even one person immortal. Therefore, at some point, more treatment does not equal better care. And this is a nice graphic, again, thank you, Hope, of looking at palliative care in connection with other issues. So I will say what most people confuse is that hospice care and palliative care, and they are different. Hospice is a kind of palliative care, but for the most part, palliative care is, we need to think of it as improving quality of life. And as we talked about, upstream at the same time as curative measures. So one thing I wanted to be sure and mention as well is that there is specialty palliative care, which we've been talking about, and then there is primary palliative care. And we see that here in Hawaii, one of the big needs that we have is for people who may not be specialists, have gotten up, may not be board certified, whether they're nurses, social workers, doctors, but that they can acquire palliative care skills so that they can be helping the people that they're with. And I think that the primary palliative care skill building is really important. And this is around things like symptom management, pain management, communication skills, all kinds of different things that really could be a philosophy of how, and an orientation for how care is being provided. So I want to put that out there. Okay, it's your turn.
I'm coming back into the camera view. Do you want to be on?
No need. Okay. No need. It's fine. That was enough.
All right. Aloha, everyone. So again, hospice care is a form of palliative care, but not all palliative care is hospice care. It's really important to define the differences. Hospice care is a specialized type of care for those facing life-limiting illness. They have a diagnosis of 6 months or less to live. It's also important to remember that doctors are guessing when they're prognosticating, when they're trying to give you a time frame. They're doing their best guess. It addresses the patient's physical, emotional, social, and spiritual needs. And it helps the patient's family and loved ones and their caregivers. So this support is not just for the patient, it's also for the loved ones involved. Hospice care takes place in a patient's home or in a home-like setting. You often hear people saying, oh, they're going to hospice. There aren't very many hospice houses available. So more than often, people are receiving the care in their own homes, supported by the hospice team. Hospice concentrates on managing the patient's pain and other symptoms that the patient made so they live as comfortable as possible. And they make the most of the time that remains. Remember, they're no longer focusing on curative treatment. We're looking at how to make the last days of life the best days of life. How do we live well all the way up until the time of death? And this can be through hospice. Hospice believes the quality of life to be as important as length of life. It's available on all the islands, and it helps to support and allow natural death without unwanted interventions while providing support to the individual and loved ones at the end of life. I really, my mom, when she passed away, she was in hospice, and I really appreciated having the bereavement services and assistance. They came in and they checked in on me for the last year after she died, which is really a nice gift to leave behind. Having someone check in on your loved ones afterwards.
I'm going to interrupt because I do that all the time. So one thing to remember is even if your loved one wasn't in hospice, hospice will probably let you come and participate in the bereavement services. So by law, they have to provide bereavement services. I've never heard of a hospice saying, oh, sorry, you didn't die in our hospice, you can't come to our support group. So if you, and especially like, oh, we were going to call hospice, but then mom died, I would put it out there that you could go and visit hospice and give them a call.
Thank you.
There you go.
Okay, I'll take you out of the limelight.
There you go.
Okay, so hospice is a great option, especially for those who are facing a terminal illness. When my mom found out that she qualified for hospice, I introduced hospice And I'm really a fan of hospice. I really want to change the name hospice, because when I say hospice, the first thing people think of is death. And it's really not meant to be death care. It's meant to be life care. How do we live well all the way up until death? So when I introduced the concept of hospice to my mom was a teacher, and she found herself in the ER, and they transferred her to the ICU. She had Parkinson's, and she hadn't had her medications. Because she hadn't had her medication, it was kind of a snowball effect. She got weaker because she couldn't eat, and she couldn't take her medications to keep her well. They tried a nasal gastro tube to feed her, and if you're unfamiliar with that, it's a temporary feeding tube which they place through the nose, down the throat, and into the belly. They tried putting it in, and she just said it was too uncomfortable. She said, get it out. We tried twice, and on the third time, she said, I don't want that. By this point in time, we didn't know when the last meal was that she had eaten, but we knew that she wasn't going to be getting any better. We called in the hospice team, and I introduced hospice as, Mom, you've been invited to the Cool Kids Club. And her eyes got really wide. She said, what's that? And I said, well, when you're in the Cool Kids Club, you get your own doctor, you get your own nurse, you get your own social worker, you get your own spiritual advisor, and you get your own aide. And that is your care team. These are the people that are going to be providing care for you. And her eyes got big, and she said, I want that. So this is why I'd like to change the thinking when you hear hospice. How do we consider hospice patients? We want to make sure that they're getting the best care possible, right? And so by introducing it as a Cool Kids Club, she was very enthusiastic about being initiated into the hospice community. But it really allows individuals to avoid unwanted ER visits. They are available 24 hours a day. When Mom was in hospice, she actually had volunteers come and play music for her. They had someone come and sit to read with her. The nurse checked in on her on a regular basis. The spiritual advisor checked in with me while I was there with her at her last days. And after she passed, they checked in on me as well. Hospice is a valuable service, and it's something that can really make the dying process a whole lot not so scary. So we want to change the focus from what's the matter with me to what matters to me. And the best way we can do that through hospice is figuring out what matters most. So the last time I was here talking to you folks, we talked about the conversation, how important it is to have these meaningful conversations about end of life, and how we should talk about this while we're healthy versus waiting for a serious illness. But when we come to the point where we have a serious illness or we may be facing a life-limiting disease, hopefully we've had these conversations so you're a little bit more prepared for having end-of-life care come. So I want to ask you to take some time and just give yourself a moment. If you were faced with a terminal or life-limiting illness, how would I want to spend the rest of my time? Where would I want to be? I encourage you to take that thought later on. We're going to keep moving, but how would I want to spend the rest of my time? Live each day to its fullest, right? So hospice will focus on quality of life rather than a quantity of life. And what does quality look like for you? So I have a bunch of pictures for you to kind of sort through and take a look at. And just keep in mind, some of these people are hospice patients. And if you look even closer, you'll see some smiles. The one on the top left corner is not a hospice patient. But if you look at all of these pictures, what they're doing is they're enjoying their last days. The one on the bottom left is a really sweet picture. When we visited Hospice Maui, they told us the story of one of their patients in their hospice house wanted to see their horse one last time. And so they brought the horse to the hospice house so that they could see the horse. This isn't the patient that you're seeing on there, but it's the same idea. Go for a balloon ride. Wow, that's pretty cool, right? Mm-hmm. So when curative treatments aren't effective and precious time could be doing or being with someone else, what would you choose? Again, hospice looks at quality rather than quantity. Some facts about hospice. Again, hospice is not a place. People receive services wherever they live. They have the aides come to you. They have the nurses come and check in on you. Loved ones and relatives are part of the team caring for the hospice patient. Hospice is not a last resort. We want to make sure that we're mindful of the words that we use, especially when it's a disease that is life-limiting. Some cancer is curable. Some cancer is not. But when we choose to go to hospice, are we giving up? Absolutely not. We're choosing the way to best live. Hospice has no religious affiliation. So the chaplains that are in hospice, they will work with whatever faith you are involved with. They respect all cultures and all points of view, and they want to give you the opportunity to discuss the patient's feelings. Hospice is not just for cancer patients, but for anyone with a terminal illness. Mom actually qualified for hospice much sooner than we knew when the nurses went and found all her records. It was wonderful. I didn't have to do anything. The nurses actually gathered all her medical information. They gathered everything from her doctors, and they were able to show that Mom actually qualified for hospice earlier, but now we were at the point where she was ready to receive it. Hospice care is not expensive. It sounds expensive, right? I mean, you get a whole medical team working with you. It's not expensive. It doesn't forego any medications or treatments, but it uses state-of-the-art medications and palliative treatments to relieve pain and symptoms. And it doesn't mean that when we've chosen hospice that anybody's failed the patient. It's not a battle that you can win if it's life-limiting. It's not about giving up. It's about living in comfort and dignity for the time one has left. It's also about being with your loved ones. It doesn't make death come any sooner. People actually live longer using hospice care. I'm going to say that again. People can live longer lives when they have hospice care. Hospice is not euthanasia. It's not physician-assisted suicide. It's actually just supporting the patient and the loved one through the end of life. Morphine prescribed to a hospice patient does not cause premature death, but it helps maintain the quality of life until the end of life. What morphine can do for a patient is actually allow the person to live pain-free. It allows the body to stop fighting the pain. Is it possible to live well even in the face of serious illness? Absolutely. Remember, there are many ways that you can live well and how you can be helped through comfort, connection, preparation, and guidance. These are all supported things that are done through hospice. The way we die lives on in the memory of those who survive. If you all think to yourselves about a time when you experienced or witnessed the death of somebody, that feeling lives on with us, and we're the survivors. So I love this quote from Dame Cicely Saunders. She is the founder of modern hospice. Again, the way we die lives on in the memory of those who survive.
So do I get to say something?
Yeah.
So one of the things I'd really like to encourage you, and Hope and I are always, Hope mentioned this too, people wait to call hospice. They wait and they wait and they wait. And if you can just hear one thing from us, don't wait. Find out what hospice is. If you're thinking, well, my grandma doesn't qualify, so it's like, you know what, go out and find what hospice is. Invite hospice in. They'll come over. They could be on your couch this afternoon. They can tell you what hospice is. I have, in all the years I've been doing this, I have never met anybody who said, I'm so sorry I called hospice. Everyone says, I should have called hospice earlier. No one told us all these things Hope just said. Wait, there's a team. Wait, you come into the house. Wait, you give support to people. So unfortunately, people wait so long that they may not be able to get all of the services and all of the support that's available. My mom also had hospice care. Actually, both of my parents had hospice care. My mom had a brain tumor, and her physician fortunately was honest with us that after the third round of chemotherapy and radiation, that there weren't any other treatments that were really going to help. And so we had hospice for 4 months, and it was just such a blessing for our family, for my mother, that people came in. They took care of my dad, who couldn't cook to save himself. We all got this support from hospice. And I just think, wow, if we'd had hospice for 4 days, 4 hours, sometimes people, they call hospice and the patient dies before they can get there. And you miss out on all that Hope just described. So we know how it works in Hawaii. Coconut wireless, super important. People ask each other for advice. So if you know someone who's they're describing, oh, my mom's so sick and she has all these things, be brave and talk about hospice. Like Hope said, call it the cool kids club, because a lot of people don't want to hear about hospice. But if you think about how are we going to care for people? So palliative care, you can talk about palliative care because it can start at the time of diagnosis, working on quality of life, and then hospice, please help us out with this, to get people to call early.
For those of you who were on with me the last time when we were talking about the documents, you can look at the pulse form, the bright green form that we discussed at the last session. That's kind of like okay, we have a pulse form. Let's see if we should ask about hospice.
Yeah.
And that's a good kind of, what would you call that?
Absolutely.
Like a
checklist?
Yeah, like a check mark.
Reminder, yeah.
When there is a diagnosis and doc says, let's do this pulse form, that's the time to ask. Should we ask about hospice? Is it time for hospice? That lets your provider know that you're willing to discuss it further. And it may or may not be appropriate at that time, but at least they know that that is something that you are considering. And
it's always so much better to have stuff ready and not need it than the other way around.
Right.
So if you can, and hospice is very happy to come to your house, tell you what's going on. They'll do this, they're trying to, they're wanting you to hire them as a service. So they will come and talk to you about this, so you can see who they are, what they're able to do and not do. So, and hospice is a Medicare benefit. Yes. So both Medicare and Medicaid. Yes. And actually all the health plans. It's a covered benefit. So go and get hospice. I actually encourage it especially for people who are concerned about leaving bills for their kids. Hospice pays for everything once you get into hospice. So there's no out-of-pocket costs except for whatever care on top of hospice that's needed. So whether that's a facility, a location to get the hospice, or hiring somebody to come in as an aide. Other than that, the medications, the nurses' visits, the beds, the incontinence supplies, all of that fun stuff is covered. Yeah, so we'll help your family. So again, I would learn about hospice and not, don't wait. This is one of those, as public health people, prevent crisis, learn, plan ahead. There you go. Okay. Okay. I'm going to turn you back to Jeannette now as she discussed the Our Care, Our Choice Act. Okay. This has just been 1 year now, right? It's been 1 year, and I'm really glad that we get a chance to talk about this and answer questions, because a lot of people are really interested in this law. I would like to clarify that Kokua Mau has a neutral stance on as it was coming into being, we have a neutral stance, and we really see ourselves as a way to get good information out to people now that the law has passed. So you can visit our website. And then, we really welcome the conversations in community. And we certainly are glad that a lot of people are at least thinking about these topics. And I'm really glad that today we get to clarify about this new law. So we call this, in Hawaii, it's called the Our Care, Our Choice Act. In other places use different terms. Some people refer to, and you can usually tell where somebody stands on this issue. And I also want to be clear, this is one of the most controversial issues of our time. So this is not simple and all taken care of. This is a very controversial issue, but it is a law in Hawaii and has been for 1 year on the books. So physician-assisted suicide, medically assisted death, euthanasia, suicide, medically hastened death. These are all terms that people use. They're a little bit different. So it's really important to be careful with language. And I therefore like to talk about the Our Care, Our Choice Act, which is more neutral about this. But the medical aid in dying is another term that a lot of people I noticed lately have been using. Okay, so let's get into the requirements. So as Hope mentioned, this started last January 1st, so we've had a year's worth of experience. So any adult residents of Hawaii with a prognosis of less than 6 months can qualify. So remember, this is the same group that qualifies for hospice. 6 months or less to live. And I will put in my plug for hospice. Hospice can be there in your house in a couple of hours. Just remember that. So like the Department of Health, Kokua recommends that anybody who is thinking about this also enrolls in hospice. So there's an adult resident of Hawaii, prognosis of less than 6 months. It is someone who is mentally capable of making decisions and that they are acting voluntarily. And they also have to be capable of self-administering the medication. So this is something you do yourself. No one else is doing it. No one else is doing this for you or to you. You must be doing this yourself. So a patient has to make 2 oral requests and separated by no more than 20 days, which means you would ask your doctor, and I want to be very clear, if someone talks to their doctor and they say, I'm interested in this, you should be very clear with the doctor. Doctor, I'm asking you this, and wait to hear from the doctor, yes, I will help you move forward with this. Because the doctor has all this paperwork to do. It's very important that everybody be clear about this. This is one of these times where, euphemisms or being vague is not going to help you. So be very clear that if you've talked to a doctor about it, doctor, are you going to help me with this? Doctor, are you going to be my attending physician? Not, we've just had a conversation. Because again, it's very important that no one is obligated, no physician is obligated to do this. That is very important in the law. Just as no patient is being forced to take the medication, no healthcare provider is forced to do this. So, patient requests. 2 oral requests. You make 1 request on day 1. Doctor says, yes, I will help you. 20 days later, you can make a second request. And in between that, you can make 1 written request. So this is not just a, hey, I'm interested in that, here are your pills. This is not what this is about. This is a very serious set of steps to help protect people as well as to give access to this. There is also something called a mental health evaluation, which is important, and then a final signed attestation. So there are 2 physicians that are needed for this process. The first one is the attending physician. So that is the person, a licensed physician in the state of Hawaii, who has responsibility for the care of the patient and treatment of the patient's terminal illness. So this is a physician who is helping with not just getting the medication, but the care of the patient, and that is called the attending physician. A second physician is needed in this process who is known as a consulting provider, who is qualified by specialty or experience to make a professional diagnosis and prognosis regarding the patient's disease. They are confirming that the patient has 6 months or less to live, as well as they are confirming that they are not being forced into this, they're mentally sound. So that is the consulting provider. We also have, and we're the only state that has a mental health counseling provision. And this can be either a psychiatrist, psychologist, a licensed clinical social worker, And they are confirming two things. They are confirming that the person is capable of making this decision and that they are not suffering from undertreatment or non-treatment of depression or conditions which may interfere with an ability to make an informed decision. So you can be treated for depression and still be getting these medications. So again, there are a number of people in our state who have stepped up, who have said that they will provide this this counseling, and this can also be in a telehealth encounter. So other things to remember or to learn about this provision, death certificate lists the terminal disease as the immediate cause of death and not that they have ingested pills to hasten the death. So that the cause of death would be cancer or ALS or whatever it is. It is not that they have used the Our Care, Our Choice Act. It is, of course, crucial that unused medication be disposed of appropriately. That is really important. It should have no impact on life insurance or annuities, and that goes back to why the cause of death is not the hastened death, but rather the underlying disease. So this is in no way euthanasia. Euthanasia is when another person hastens your death. That is not this. People are choosing to do this themselves. So that is a big distinction with euthanasia. And as I mentioned before, organizations, facilities, providers can participate or refuse to participate. That is their right. So it's very important to say that this must be voluntary. So just things to be considering. It is prohibited by federal law to use any federal monies for anything associated with this in what they call assisted suicide. So federal money, so Medicare, those plans you cannot use Medicare money to pay for the medications for this. It's kind of new what all this means here, so we're still trying to figure this out. I won't tell you that I definitively know how each health plan stands on what they'll pay for and what they don't. So people are, again, encouraged to ask their providers about that. Our advice or our comment usually is that you should assume that you're going to have to pay out of pocket, at least for the medications. However, it is really important to say that people should feel that they can discuss this option with their providers. And it should be, and it is also really important that it's not just discussing the Our Care, Our Choice Act, but discussing what other options are available to somebody who is living with serious illness and maybe coming to the end of their life. So we talked about hospice. You know, it is really important that people understand what hospice is. It's really important. So for instance, last year in Hawaii, about 10,000 people died who would be eligible for hospice. So for us, it's really important if people are asking their provider about the Our Care, Our Choice Act, they need to also be hearing about hospice. We really would love for more people to be taking advantage of hospice and using those really important services.
Also, it goes to say that it is a 20-day period.
Right.
So having hospice in place during that time can be crucial to supporting the patient. Having hospice in place prior to that 20-day waiting period is even better.
Exactly. So when I talk to providers and talk to people who may actually be counseling people, I always say, so think of this. If someone has come to you, there's usually two reasons somebody's coming to you. People may be coming because they're just interested in this new law. How does it work? When my time comes, what would I do? That is general information that you can be giving and send out to, send to the Kokua website or Department of Health website. If somebody is very much suffering and feels that this is an option they want to understand for their own use, yes, you need to discuss their options with you, and hospice can be at someone's house in 2 hours. So while someone may be very convinced that they want to use this act, that is 20 days until they can do that. Whereas if they are suffering, as we've spoken, physical, emotional, spiritual suffering, that can be alleviated and addressed this afternoon. So we really encourage people to be providers when they talk with people to discuss all of the options that are available. And that's why, as this last point here, an office visit where you're discussing the Our Care, Our Choice Act will be covered because you're talking about chronic disease, chronic illness, and especially if somebody has something that is ongoing. I mean, that's why you're talking to your doctor. So you should not see it as the only option. It's one option. We, again, we spoke about hospice. That's a really important option. All the things we talked about under palliative care, also really important. So it's crucial, and the law is very clear that when providers are talking about the Our Care, Our Choice Act, that they are talking about all the options that are available. Okay, so some organizations and individuals here in Hawaii require someone to be in hospice care. The state recommends it for the best care at the end of life. And so again, for us, we really recommend that. At this time, on this day, there are no medical directors from hospice who have agreed to be the attending physician, which means that you need to find someone else who would be that attending physician. Again, it's a choice. It's a choice that every provider has the right to make or not make. But I think it's also very important that all of the hospices are very clear that they are supporting patients. They will never abandon a patient who chooses this. All of the hospices have said that. And then if you think back to what Hope described the hospice team is, they focus on communication with the patient, the family, caregivers, and providers. They provide comfort in all the ways that a person might need comfort: the physical, spiritual, emotional, psychological, social, financial issues. That's what the hospice does, supports the person through the journey. So they're going to support the patients, but they are not the ones who are the attending physician who is writing the prescription. And then at the end of the day, the person takes the medication themselves. So the hospice is a key part of the team that supports people. And as I said, all of the hospices are very clear that they will never abandon a patient. So just to review some of these key points, attending physician is responsible for ensuring that all of the requirements are met. There's a 21-step process that's laid out on the Department of Health website, and we link to it at all. And providers are in charge. It's very clear who is it that's allowed to do what. So really the doc has to, I'll be honest, the key person in this is finding the attending physician. Again, it is something that's voluntary. And after 1 year, I think it's very clear that it may be difficult for people to be finding that attending physician because a lot of physicians are not participating. I will say that Kaiser has a program where they are helping their patients to ask this. So they have they have dedicated people and a very outspoken physician. For people who are not in Kaiser, then they will need to look other places to find that physician. So as I mentioned too, we really recommend that everybody enroll in hospice when they begin the process. And really, if you think of all the 21 steps and the 20 days, you want to begin it early. And again, there are really limited providers who are participating in this, so it would be important to figure that out. So one of the key questions we get is to who is requesting this? Who are the people that are asking about this? And why are they asking? So the first question for the first set of slides here is who is requesting medical aid in dying and why? And these are things that are, these are more around existential issues in my framing. So loss of autonomy, less able to engage in enjoyable activities, loss of dignity, loss of control, burden on families. Inadequate pain control or fear of inadequate pain control is down 25-35%. So, and again, it's not even that they had inadequate pain management, that they were worried about it. So these are much more existentialist questions. Am I a burden? I'm losing my autonomy. This is what people are telling us and what we hear from people about why they're interested in that. So this is a slide that summarizes what we've learned here in Hawaii. And it is 27 people got a prescription. 19 of those people died, but 14 people died after taking the medication. So 27 prescriptions and 14 people died taking those medications. So that was the data at the end of the year.
And it's important to say that 10,000 people die.
Right.
So
yeah. So 10,000 people die every year, and we had 27 people that asked for a prescription and 14 people who actually died taking the prescription. So again, this is occasionally I get frustrated because people are very focused on this law and saying, well, now we don't have to worry anymore. Like, 10,000 people died. Let's focus on getting more hospice, more good conversations. Did you do a post? Where's your advanced care planning? Is your family involved? These are all things that are really, this is what's moving the needle. I welcome a lot of conversation that comes out of the new law, but I think it's really important to say, yes, 10,000 people died last year that could have used hospice care. So, so the main causes were cancer. That was the main reason that was the main underlying diagnosis that people had. I think there was one person who wasn't in hospice, but I can't remember why that was. 12 physicians wrote prescriptions, so somebody had 3 prescriptions. And it took between 22 and 37 days to get the prescription, which I thought actually was pretty good considering it was the first year, new thing, nobody quite knew what to do. So that's the length of time.
As Jeannette mentioned, Kaiser has a process in place, but theirs is already well defined. Outside of the Kaiser system, people are still trying to figure their way out and how to get this done.
Yep, exactly. And so to clarify, in Oregon, they've had this for about 25 years. So a lot of experience has come from Oregon, and Oregon has then where it's much more integrated into the system. For us, it's new. We're learning about it. We're figuring out what the implications are. For us, we're really interested in how does this new law spark the conversations we're talking about, encourage people to learn about what hospice truly is and get into hospice, as well as have good conversations with their families, like look for support. People who are concerned that that they're a burden to their loved ones. Well, did you talk to your loved ones? That would be good to figure that out. I also really encourage people who say, well, this is what I'm going to do so I'm not a burden on my family. Well, it's really good to talk to your family and make sure whether or not they feel that. Because if you found out later, oh, my mom did this without telling me so she wouldn't be a burden, that's a burden. I think it's important to talk these things through. This is new for us. This is a new thing of what does it mean. So I think that there can be some really good conversations about this, but I think it's important that we recognize, I personally think it's fair to talk to your family about it. People don't have to, but I think that's fair. The family has to live with, these decisions.
I think it's really important to have these conversations while we're healthy, to start these conversations while we're healthy. If this is something that you'd be considering somewhere in your future, it's throw it out there and talk about it. Spark that conversation. How do we care well for each other? We have to know how to support each other through times of illness, through times of hospice, end of life. The only way to know how to support each other well is by talking about it. So your band of people might show up, and when they show up, they want to support you. They want to be able to help you, but they need to know how. So have these conversations.
We just had someone ask, please repeat the amount of required days from request until they can get a prescription.
20.
20 days, okay.
Yeah. First request, 20 days later, second request. So what you can do is you can identify where a pharmacy is that will fulfill the prescription, and there are several that are out there. So again, I would go to the Department of Health website, look for the checklist, and then to look at all the pieces there. Okay. Were there other questions?
We have other ones for later. Okay. Kind of
Good. So just to be clear, so that if you want to know more about the Our Care, Our Choice Act, the official state website has a ton of information. We have 2 pages, one for providers, one for people, for the public with good information. And then we've also linked to the Department of Health. And then the California Coalition for Compassionate Care, which is sort of a sister organization to Kokua, they have some good information as well up there. So there's good resources out there. Just sort of coming to the end, we actually we hope that you guys will be interested in Kokua and some of the activities that we're doing. So we invite you onto our free mailing list. We don't share your address with anybody, but we can tell you what's going on out in the community, events, trainings, all kinds of things happening. We also have all sorts of free materials that are up on our website, so you can look for the toolkit for providers, but there's a lot of really valuable information there. So there's really no need to reinvent the wheel in any of this. A couple of years ago, we created translations of some of the key materials, specifically the Advance Directive and also the
POLST. We have things on
Advance Directive,
on CPR, 10 different languages.
Yep, exactly. So feel free to, again, download all that material. And then we hope that you guys will be inspired and say, like I said before, oh, my mom's church needs speakers, or my book club, or Hope goes out a lot and does a lot of talks. You can see on the calendar on our website, she was at the Pearl City Library, Alulike, senior groups, churches, temples, all around town. There's a lot of people who actually do want to talk story about this, but they usually need a push from somebody. So if you can do that, that will help to sort of break the ice and get things going.
We're actually going to have a community event at the Seventh-day Adventist Church in Kailua tomorrow.
Right.
So we'll be there doing this again. So
what time?
1:30.
1:30. Feel free. Is there food?
There will be food.
They always have food.
They always have food.
Seventh-day Adventists
They like
always
to
have
eat.
really good food too.
Yeah.
Yes, exactly. So people are, so you can go on the Kokua website, on the calendar, Seventh-day Adventist. And if you're thinking, oh, I wish they would come to my workplace, give us a call.
Right.
Yep. We also have people that work over on Maui, so we like that.
We are also promoting a workplace wellness type of service. So if your organization would like to have us come in and do this as a wellness initiative with your workplace, we're happy to do that.
Yep.
We will custom tailor everything to suit whatever needs are wanted.
Yeah, so the workplace wellness, I think a lot of workplaces are trying to support, especially family caregivers. And this is a way we can come in, we can do trainings, we can bring the materials. We all know we're supposed to lose weight and take the stairs and all of that, especially you guys, good public health. But we really see that this can be a way to help with the mental health of people who are trying to help their loved ones with serious illness, help get things in place or address the crisis that's out there. So we really hope you'll think about this as Hope said, the workplace wellness. We've actually been collaborating with EUTF over the last 2 years, going to health fairs and doing some talks out on site, and a lunch and learn kind of a thing. We're really happy to do that. So I hope you can think of us.
Yeah.
And then here's some pictures of some of the materials we mentioned before, and here's our contact information. Questions?
Okay. So again, folks, if you folks have any questions, please feel free to put them into the chat box, or we have a Q&A option as well. So I had a first couple questions actually from the beginning. How does it work for Alzheimer's patients? How early can we involve palliative care?
So that's a really good question. And I think it's important to say that we don't have enough palliative care for people with Alzheimer's. Mm-hmm. So I would always talk to the doctors about that. And then again, especially if somebody's outpatient, Alzheimer's is not one of those diseases that's covered to get the HMSA supportive care. I don't know how the VA is approaching it. But again, I would ask. And it's always good to say, you know, hey, how are you helping me care for my loved one with, so I think the key thing about finding out what's available, talk to the doctor, talk to the health plan, figure out that way, because that's how every health plan has a different approach.
Do you want to talk a little bit about what's happening in the palliative world?
You mean with the educational stuff?
Yeah.
Yeah. So we're actually really pleased that we're gonna. Last year we passed a law. The A-Team was a collaboration with the Department of Health, Kokua, and the American Cancer Society to increase access to palliative care. And that law passed. I will say it was the first time money was put into palliative care. It's really exciting. So Hope and I and the team at Kokua are going to work on an educational program, helping people to understand what palliative care is, where they can find it. So that's something we're really pleased about. And we also are looking at some other important things like what is a firm definition of palliative care? It's a relatively new field. There's some confusion. We like this much more robust definition of palliative care, that you have a team approach and people who are trained, as opposed to, oh, I sent my social worker to a lunchtime talk with Jeannette and now she provides palliative care. This is not good. No. What we need really is good team. We need good training and ongoing training and all of that. So for us, it's really exciting and great to think that together we're going to figure out how do we help expand the access to palliative care and expand how people with serious illness are cared for.
We have a question. Due to the 6-month life expectancy requirement, do oncologists and neurologists routinely refer their patients when their patients meet their requirements
for hospice? For
the medical aid and dying?
Oh, no. So,
and hospice, sorry.
Okay, so let's talk about hospice first. So at 6 months, so let's just be clear with hospice that most doctors are not referring their patients to hospice in a timely way. Most doctors are waiting to hear from their patients about hospice and it's for us frustrating because the doctor will say, oh, I don't want to worry somebody, so I didn't bring it up. Oh, I don't want the family to freak out, I didn't bring it up. What we're finding is it's much better if we ask and say, when my dad's time comes, he's really interested in the hospice. When do you think that might be? You should never wait to the doctor to bring it up. They're busy. It's a more complicated conversation. We need to help people out by saying we want palliative care. Wouldn't you say?
Yeah, you have to ask for it. It's unfortunate, but being aware is the first step. And then knowing that you have that as an option, you're arming yourselves with some good tools that can come in handy later in the future.
Yeah. And I think, it's always interesting for me when I hear physicians, like you went to school for a long time, and they say, oh, I don't want to scare my patients. Oh, it's too early. Oh, I don't want to bring it up. So it's kind of frustrating, and it's frustrating so I work with amazing physicians who just have incredible communication skills and help people like Hope was describing. It's not giving up hope. It's actually helping people live every day. Live every hour. That's what hospice is helping, support the team, all of that, but there's still so much misunderstanding. And I would say there's misunderstanding about hospice and there's misunderstanding about palliative care. And people are also waiting very long to refer people to palliative care. So we're hoping with this contract with the state that we'll be able to help with some of that misunderstanding, that we can do that.
There's also many stories out there about people graduating from hospice.
Mm.
They actually get such good care that they get better.
Yeah.
And they get kicked out of hospice.
Yeah, so we call it graduating from hospice. And somebody from Hilo was telling the story of somebody had just, they were finally admitted to they have a beautiful, beautiful hospice in Hilo, hospice facility through Hawaii Care Choices. And finally, everybody got to sleep. The patient got to sleep. The family got to sleep. A team came in to look at the meds. Somebody was on a whole bunch of meds that were counterindicated. Their pain got under control. They were helping with their breathing. A chaplain came, was talking to the family. The person got better and went home. Like that's what can happen. And especially with the fragmented care that we often get, really who's managing the meds, who's helping with these things, what is the plan? And I know for those of us that take care of people, it's so frustrating that there's not a team. Like, why am I I didn't go to med school. Why is this happening? So oftentimes hospice is the first time that people really have this managed situation, which is really what we need from the beginning. Mm-hmm. So perhaps the question was about, are people being referred to the Our Care, Our Choice Act as well? Mm-hmm. And let's be very clear, no. That is something that you need to bring up with the doctor. I don't think any doctor is going to say, hey, are you interested in the...
You want some meds?
No, like that is just not happening, right? And imagine a physician no, that is not happening. So if somebody is interested in the Our Care, Our Choice Act, they really need to actively ask their doctor about that. And that's really what we see. So, which is good. I think I'd be freaked out if my doctor asked me that.
Well, that's funny because someone else, like supplemental question to be like, is there a plan to formulate lists of approved pharmacies and physicians who are on board with?
Absolutely not. No, I did mention it before. I don't mean to be flip. Yeah. Okay. I was fed, so it's okay. But, no, because this is a very controversial topic. Mm-hmm. This if you remember when the law was being discussed, there were demonstrations on both sides. There were hundreds of people came out in whatever color shirt. This was something that really got people concerned. The Catholic Church is very concerned about it. A number of faith communities are very concerned about it. I wouldn't put my name on a list. I think if you want to know about it, there's you can figure that out. There's a group of people that are out there that you can find them. There's also not a list of physicians, and I think that's also, like people are being spammed for all kinds of things nowadays, and I wouldn't put it out there. I think it is, and it's also a personal choice, and it should be, it must be a private conversation between a patient and a physician, just like anything else. So I think that it's really important that, that we recognize how important this is. It's serious, and there is not a list. There won't be a list in California and Oregon. Oregon after 25 years, there is no list. Mm-hmm. In California, there are 2 physicians who have a practice that focuses on it, so they can be found. But no, that's not going to happen.
Awesome. Okay, we have another one that's pretty long, but I want to make sure that there are multiple parts to this question, so I just want to make sure we get through it. As a pain advocate, what can we do to help doctors understand that chronic care management and pain management can be used in pain management settings for illnesses where the qualifications are unavailable of a cure and persistent symptoms? Even when presenting physicians with palliative care certificate to help them, they still insist that palliative care is only for end of life.
Who says that? We don't know. Yeah. So, okay, that's always hard because, all right, so the end part for people, so it's important for providers to understand what palliative care is. So if you encounter providers, physicians, nurses, nurses, anybody who thinks palliative care is just end-of-life care, okay, we'll forgive them that because that is what the community thinks, but send them to the Kokua website, send them to the Center for the Advancement of Palliative Care. We need to really be educating people about this. And so if you can help us identify who those providers are that are misunderstanding what palliative care is, that would be really important. I'm happy to strategize offline what to do about doctors who aren't taking pain seriously, because that's bad. And I was telling you guys earlier, there was an echo talk yesterday by an excellent physician here at Queens for folks in the Pacific Islands about pain, how to assess pain, and his first slide is always believe the patient. Always believe the patient, because you don't know what's going on. So we really need, as a community, to step up. And, you know, part of the challenge is that we see the opioid crisis, like, oh my gosh, all these people scamming for drugs. No, stop. We need to help people manage. There is a pain that we need to be managing. That's what we need to figure out, and not just toss out everything. Well, you know, not just say, well, nobody gets pain meds, nobody needs this, or you only get pain meds at the end of life. That's draconian. Oh my gosh, don't sign me up for that community. Yeah, so I think it's, you know, and again, I'm happy to strategize with you with these physicians who don't, and it wouldn't necessarily be me. I'm thinking of peer education, because we have training opportunities. There's stuff going on. Maybe there's a subtle way of getting, because doctors, I think, sometimes are less able to hear things than other people. And it's kind of interesting for me in public health, when you look at education, that educating doctors is really hard, getting people to do that. So I'm happy to strategize with people.
And remember, hospice is a type of palliative care, but not all palliative care is hospice. So it's important to keep that in mind.
Yeah. So, and you know, for people who are, again, it's, did I cover the points?
Yeah, what can we do to help doctors understand pain management?
Yeah, so, you know, there's grand rounds at almost all hospitals. What we've done as a technique, like for understanding POLST, is that if we can figure out who that doc is, if they're, for instance, connected to Queens, we can have people at Queens reach out to them. If it's somebody from Hawaii Pacific Health, somebody from there can reach out to them, because most docs are connected to a larger system. And both, you know, Queens, Hawaii Pacific Health, Castle, Kaiser, we work with all of them, and we work with docs who are excellent at this. And this is part of the, you know, in terms of peer education and outreach, and we have, you know, maybe we can, in a more subtle way, try and get to them for some good education. So I'm happy to work with anybody.
Awesome.
They should contact me.
Someone had asked if you could please clarify, earlier in the presentation, I thought a slide said hospice is only for patients who are not facing strictly end of life.
Opposite.
That's opposite.
Yeah. So you would get into hospice with a 6-month or less diagnosis.
Gotcha.
And that actually, it tends to be an issue, because it's not easy to, like Hope said, it is a bit of guessing, and doctors tend to be overly optimistic about how long someone has to live and all of that. We've seen some pretty disturbing, like, presentations about how, I don't want to say it out loud, but I will, bad doctors are at prognostication, and they don't get the timing right. It's usually I think by a factor of 8. So if she said, I have 8 months to live, it would be, they would have 1 month to live. So it's and so for us, it would be nice if hospice wasn't quite so strict of 6 months. But really, the key question is access to the care.
And we have one last question: who or what agencies provide palliative care?
Right, we had a slide there somewhere. Can I go back to that?
Yeah.
And I want you to let me know if you find other people providing palliative care. So I will say I've seen online that somebody said they provided palliative care because they went to nursing school. So that is not the type of palliative care that we're talking about. What we really are talking about is somebody that has a team approach, interdisciplinary, more than just an afternoon training. So these are the places where you can find this. So again, you can get the palliative care inpatient. We're making good progress with that. It's the outpatient that really is the challenge. So there is certainly not enough even inpatient palliative care, but it's that outpatient piece. And part of the challenge too is because CMS and Medicare doesn't pay for it. So we really are hoping, and we are working with our Medicaid, the MedQuest office, to get palliative care as a covered benefit for MedQuest patients, which would be great, because it does come back to who pays for what. So we're really glad that MedQuest is interested in this. You know, we work with all the health plans, and people are working on things. I think it's just a matter of trying to, again, I hear from people, it's really important we have to do that, and the funding mechanism isn't there. Mm-hmm. So that's why we're sort of the good thing, you know, in Hawaii, we're ahead of the curve on this one. We really, Kokua, we're going into our 20th year, so we've been doing this for a long time, built this good community, but we're also small enough that people are worrying about each other and taking care of each other. And, you know, my colleagues at health plans are genuinely trying to figure out how to make this happen. So this is the inpatient, outpatient, and then the in-home list. So if somebody knows of another palliative care program that's robust and is, I don't want to, like, how to say it, real palliative care, let us know. We're really interested. We're interested in that.
Awesome. Well, thank you. I'll throw it back to Steph so she can close us out for the day. All right, Steph.
Thank you everyone for joining the webinar today. I especially want to thank Jeannette and Hope for hosting the webinar today. It was super informative. We're getting a lot of thank yous on the chat too. Mahalo to Queens for hosting us in their teleconference room. Couple reminders, don't forget to complete the evaluation that I will be sending out here in a few minutes. We are asking if you can please get that completed by Monday. If you don't receive the certificate of attendance from us within 2 weeks, definitely shoot either myself or Amaka an email. Next webinar coming up on Friday, March 20th. It's Beyond Resistance, Understanding Ambivalence in Treatment, and that will be hosted by Dr. Joy Tanji. And I will be sending out a link to register for that webinar. But until then, we hope you enjoyed today's webinar, and we will see you in March. Thank you.